All right. I have nothing to disclose, no conflicts of any interest. The objectives for today's presentation, I want all the participants to understand menopause and some of its symptoms, learn why bone health really matters during the perimenopausal time and also after menopause has occurred. To discuss some osteoporosis prevention, lifestyle modifications, briefly discuss medical management of osteoporosis. That in itself could be a whole lecture. And then understand how hormone replacement therapy, another big buzz, helps symptoms and with bone health. All right, so what is menopause? Often patients will ask me, how will I know if I'm about to go into menopause? The date of your final menstrual period after the absence of periods for 12 months is considered menopause. The average age of menopause is 51.3. 95% of women will experience menopause between the ages of 45 up to 55. So if you're experiencing menopause, which is cessation of your period before the age of 45, that's considered premature menopause, which we'll get to later is a risk factor for things like osteoporosis. An important sign that menopause will occur in the next 1 to 2 years is if you miss two periods in a row, so absence of bleeding for greater than 60 days. What is menopause transition? Patients will ask, how will I know if I'm getting close to menopause? Often, you'll want to get your hormone panel checked, which is a good way to get an idea. However, unless you're in that position where you're skipping periods, your hormone panel might likely be normal, but it doesn't mean that you're not experiencing the symptoms you're experiencing. So, menopause transition is defined as the period of time with persistent irregular bleeding plus menopausal symptoms. So, those include hot flashes, poor sleep, changes in mood, and this would occur prior to the final menstrual period. Many women sadly go into this transition without any information about what may occur, or even worse, misinformation from things that they may see on social media. So I love that we do these community lectures so we can educate our patients and help them feel empowered as they enter this transition. What is perimenopause, and how long will these symptoms last? So, perimenopause extends from the years before your final menstrual period to when menses are irregular and continues until 1 year after the final menstrual period occurs or menopause. Most bothersome symptoms will be around the age of 50 to 54, and those symptoms can last for almost 8 years. And then premature ovarian insufficiency is when your final menstrual period is occurring before the age of 40. Some facts about bone health. Women can lose up to 20% of their bone mass during menopause, which is very wild. And that's why I put that little cartoon there. I keep finding these all over the house. My doctor says bone loss is normal at my age. So, correct, it is normal to some extent, but there are things we can do to help decrease that acceleration. 1 in 2 women over the age of 50 will experience a fracture due to osteoporosis in their lifetime. And just to put that into perspective for you guys, this incidence is greater than that of heart attack, stroke, and breast cancer combined for women, which is wild. And then 1 in 2 women who experience hip fractures will not return to their previous lifestyle, and 20% will die as a consequence of their fracture. So the consequences of osteoporosis and maintaining your bone health is very, very important. So I know we all think of this cartoon in the middle that you see here when we think of bones. I feel like that was like my first thought of what bones look like too, but in fact, bones are very complex. Bone is a living tissue. It's constantly being remodeled, undergoing building and resorption by two different types of cells. They're called osteoblasts, which build, and osteoclasts, which resorb or break down bone. Peak bone mass will occur in our early 30s, and after that, it is to some extent downhill. We will be constantly losing more bone than we build. Um, if you see on the left side, you see bone mineral density. This is the bone mass. This is something that we can test for when we do things like a DEXA scan or a bone density scan. You'll see bone tissue properties. This is the materials that the bones are made of. And then the microstructure, which is a like a zoomed in picture of what a cross section of bone would look like. You see the outer cortical shell right here, and then the inner trabeculae. And in an ideal situation, we would want more connections for more strength. So, in addition, estrogen, right? This is a key player for women and multiple organ systems in our body. In addition to regulating our menstrual cycles, estrogen affects the reproductive tract, the urinary tract, the skin, your blood vessels, bones, breasts, hair. And then when your estrogen levels are decreasing as you enter the perimenopausal and menopausal time, it does have problems with decreasing your bone mineral density, causing those osteoclasts, which are the ones that resorb the bone, to act more rapidly. So, this is some graphs depicting how estrogen declines during the menopause transition. So, this is age 50, average age of menopause right here, 51, and you see this rapid decline. And then you see accelerated bone loss after menopause. Estrogen plays a critical protective role in bone health. So after menopause, there is a sharp decline in the first 5 to 7 years. And then without estrogen's protective effect, we see increase in bone resorption, and then that decreases bone density and increases fracture risks as well. So these are some musculoskeletal changes that occur in the absence of estrogen as women are entering menopause. Um, Joints, muscles, bones, they all have estrogen receptors. So we'll often hear a sign of menopause is just feeling very achy, having pain, frozen shoulders, increased risks of fracture. Um, and this is, one of the things that our patients come to see us about, and often will say, oh, well, just go and exercise more. But we have to also take into consideration that some of these lifestyle modifications are limited by pain, and there's an actual mechanism behind why we're experiencing that pain. There is, like we had mentioned, an increased risk for fractures. And we'll go through some more risk factors, but one of the biggest risk factors is a low BMI, less than 21. So it is important to maintain a healthy weight as you're transitioning into menopause. Due to decreased estrogen and also decreased testosterone, which estrogen is um, converted to testosterone in the peripheral fat cells. We see diminished muscle mass and strength and pain as well. And then lower testosterone is in turn associated with fatigue and weakness, which will limit our patients from exercising, which is something that is helpful for this. It's a vicious cycle. So, what is osteoporosis? It's often called a silent disease with no symptoms associated with decreased bone mass and strength. If you look at this zoomed in picture of normal bone versus osteoporotic bone, you can see how this bone looks nice and healthy. There's lots of connections versus the osteoporotic bone looks weak. This area looks very thin, and there's more pores. It's considered porous. And often women will present with a stress fracture or some sort of injury. That will eventually lead to their diagnosis. So, screening is very important in these cases. Who, when, and how to screen. So, all women greater than the age of 65 or older should be screened for osteoporosis, whether or not they have any risk factors. Um, Postmenopausal women who are less than the age of 65, we would screen if they have increased risk factors, and then we would determine those by a clinical risk assessment tool called the FRAX score, and we will be chatting about that in the upcoming slides. Um, we, as physicians, as providers, we use our patients' clinical history, including their any like fracture history, family history, FRAX score, and then the bone density scan to assess if our patients need screening and subsequent treatment. Here are some risk factors. I know everyone's going to go through and be like, that's me, that's me, that's me. So if you find yourself saying that, then it's very important to make sure you're talking to your doctor about whether or not you need screening. So family history, which I feel like in medicine we see family history come up with everything. So family history of osteoporosis and or fracture, low body weight, smoking, even if it was a history of smoking, excessive alcohol use, a sedentary lifestyle, vitamin D deficiency, a patient who's having frequent falls, premature menopause, surgical menopause, thyroid disorders, long-term steroid use, and then certain autoimmune diseases as well, such as rheumatoid arthritis, lupus, and then also inflammatory bowel disease. So some things to keep in mind. So we mentioned the bone density scan, and a lot of my patients have questions about this. It sounds like there's a lot of radiation involved in it, and everyone thinks like, oh, it's like the mammogram, it's gonna hurt. So we wanted to raise some awareness about the bone density scan. It takes about 20 minutes. We look at X-ray absorption in the hip and spine to determine bone mineral density, and compare it to a young adult average. We call this in statistics a T-score. They also provide a Z-score, which is how you compare to individuals that are age adjusted, so someone in the same age as the patient being scanned. It is painless. You lay flat on a table. You're not in an enclosed space. And then how to interpret the results. I mean, your provider will hopefully be doing that for you. A T-score of -1 or higher is considered normal bone density. -1 to -2.5 is indicative of osteopenia or low bone mass, which kind of puts up flags that we really need to start doing something. And then -2.5 or lower indicates that you are diagnosed with osteoporosis. It does involve a very low radiation risk. And just to put that into perspective, it's about 1/10 of a standard chest X-ray. In addition to your DEXA score, there is another score that we look at. Some centers are not all centers are reporting the trabecular bone score, but it does come in handy. So this is a measurement that's derived from a 2D DEXA, like a PA, posterior anterior spine image. It looks at the variability or how uniform the distribution of the 2D images, which correlates to the microarchitecture of the bone tissue. So, for example, if you look at this patient who has pretty similar actually bone densities on her DEXA scan. Then if you add the TBS score, the trabecular bone score, it can show how this patient, even though her bone density is almost the same with a lower TBS score, has altered trabeculae, which makes the bone weaker. And this does come in handy when we're calculating our patient's FRAX score, which I'm going to talk about in the next slide. So, what is a FRAX score? It's a fracture risk assessment tool. It estimates your 10-year probability of a major osteoporotic fracture or hip fracture. It combines the patient's clinical risk factors with or without a DEXA scan, and then with or without also that TBS that we talked about on the slide before. It includes things like age, BMI, smoking, any long-term steroid use, family history, and then you can add the T score from the DEXA, and this really helps to guide treatment decisions um, in patients who may not meet osteoporosis criteria based off of their DEXA scan. However, they have a greater than 20% major fracture risk or greater than or equal to greater than 3% hip fracture risk based off of the FRAX score, may be a patient who we still offer treatment for osteoporosis too, because they're considered high risk. So this is just a screenshot. If you fill out the FRAX questionnaire, you can even kind of do it for yourself if you want. The calculators are available online. But this is something your provider should be calculating for you when you go to see them for your annual exams and your wellness visits. And this is where you can add your T-score from your most recent bone density, and then you can adjust it with the TBS here as well. And then this patient has a osteoporotic fracture risk of 10% and hip fracture of 1.8. So if this number is greater than 20 or this one is 3, even if you don't have a T-score that is consistent with osteoporosis, you may have osteopenia, then you still might be a candidate for medical management of osteoporosis. So I like to think of treatment and prevention using this pyramid because all of these things are stackable, they go hand in hand and are not mutually exclusive. So big things you want to think about, that top peak, which is just one small portion, is any prescription medications that your doctor or provider may recommend if you're diagnosed with osteoporosis. Diet and exercise, which I feel like it's so easy just to say that, but we'll go into a little bit more details about that. And then fall prevention. Biggest thing we worry about with osteoporosis is the sequelae of it, which is a fracture. So preventing falls, being safe, is one of the most important things, and it should not be overlooked. So prevention tips, we want to maximize our peak bone mass before we get into menopause. So if you think back to that slide where it was the multiple things contributing to your bone health, you want to think about those building blocks. So a healthy diet rich in calcium and vitamin D, regular weight-bearing exercise, avoiding tobacco and limiting alcohol, specific calcium recommendations, best from food sources, and then you can supplement if needed. Women between 19 to 50 should be having 1,000 milligrams daily. And then postmenopausal women above the age of 51 should be having 1,200 milligrams. Vitamin D is also a key player. It actually helps to absorb calcium because without vitamin D, you wouldn't be able to absorb and use the calcium that you're consuming. This helps to support muscle strength. And the recommendation is about 800 to 1,000 international units. And then if you are someone who's at risk for deficiency, you should be checking your levels to see if you need even a higher of a dose. Preventing bone loss is a really, really important concern for women during menopause because as you age, you are more prone to fractures and falls from just limited visualization. Like your eyesight can get worse. You have decreased muscle mass. And then, on top of that, if you have osteoporosis, you're at higher risk of having a fracture. Lifestyle modifications, exercise, exercise, exercise. And the most important thing for that is weight-bearing exercise, which basically includes everything other than swimming and cycling. So walking, jogging, doing strength training 2 to 3 times per week. My patients often say, I can't lift heavy weights, which I usually tell them is totally fine. Even 5 pound weights is really helpful with this. And then balance training to help prevent falls, things like yoga, tai chi, even doing chair yoga. Like you don't have to do something very advanced. And then consistency is key here. I always encourage my patients to quit smoking for multiple reasons, not just osteoporosis prevention, limiting alcohol to less than 1 drink per day, fall prevention strategies at home, and then maintaining a healthy body weight. I really like this website. It's Bone Health and Osteoporosis Foundation. I have a link for it at the end. But basically, there's like 4 different types of exercises, posture exercises, which I have an example of here, to improve posture, reduce any like rounded or slopping shoulders. They can help decrease your risk of breaking a bone, especially in your spine. Hip and back strengthening exercises, which there's an example of right there as well. This would strengthen muscles in your back and hips as well to prevent a spine fracture. There's also balance exercising and then functional exercises, which can help in everyday activities, decreasing your chance of falling and breaking a bone. Dietary goals, like we had mentioned, you want to aim for about 12,000 milligrams of calcium a day. That all translates to 3 to 4 servings a day. You can think of, milk, cheese, yogurt, but there are other sources of calcium as well if you can't tolerate pure dairy. Um, Calcium supplements are also an option. 2 types, calcium carbonate and calcium citrate. And then vitamin D, we want to aim for at least 800 international units a day as well. My patients will often ask me this. Calcium supplements, is one better than the other? I like to think of them as pretty much equal. There's a few things that I would recommend calcium citrate over calcium carbonate. So calcium carbonate is about 40% elemental calcium. It's the most common type of calcium supplement. And it is best absorbed with a meal. So it's really important to take that with either breakfast or dinner. And then examples of this would be like Tums or Caltrate. These are very commonly found over the counter. Calcium citrate is 21% elemental calcium. It is absorbed a little bit more easy, but each pill does have less calcium, so you might need to take more pills to get that amount of calcium dose. And it is usually a little bit more expensive as well. An example of this would be Citracal. This is better if you are taking an acid blocker. So if you are on a something like a proton pump inhibitor for acid reflux, then you definitely should be taking this form of calcium. And it is a bit less constipating for any of our patients with IBS as well. I thought this was interesting. I wanted to mention how to read labels. I mean, we're asking our patients to eat more calcium, but sometimes it can be a little bit confusing as to how much we are actually getting in the food that we're eating. You'll usually find calcium as a percentage. This label I happen to find just had the milligrams listed as well. But usually it'll just say a percentage. So if you want to convert that to how many milligrams you're getting, the RDA uses 1300 milligrams because that's the recommendation in adolescents. So you would just multiply 1300 by the 25%, and this, it's not very accurate, but it is about 325 milligrams of calcium in this product. Um, all right. So, now that we've kind of talked about the preventative and lifestyle and diet and exercise, I do want to also mention medical management of osteoporosis. Um, there sadly is nothing that's curative. It's nothing that's going to fully reverse and cure you of osteoporosis. However, there are treatments that you can stay on for X number of years, and then your doctor will likely recommend doing a drug holiday, and hope that with the lifestyle modifications, diet and exercise, there is some reversal. So there are FDA approved treatments for postmenopausal osteoporosis. I like to think of them in like two different categories. There's anabolic, which is bone building, such as a teriparatide. These are parathyroid hormone derivatives. And then there's anti-resorptive, which a lot of us may have heard of bisphosphonates. So bisphosphonates are the primary first-line medications for treating osteoporosis in postmenopausal women. They are designed to reduce your fracture risk. They inhibit osteoclasts, which resorb the bone. They're the cells that eat away at the bone, and then in turn will increase bone mineral density. Often patients will have side effects, so you have to take them in a very particular manner, like in the morning on an empty stomach, sit upright for 30 minutes after taking it. They'll often report like upper GI side effects such as nausea, vomiting, heartburn. And then those can be avoided by doing an IV bisphosphonate, which is an option as well, and less frequent dosing as well. And then some of the rare side effects, however, you can see with bisphosphonates, you can get femur fractures actually from it, which is kind of counterintuitive since it's supposed to be building bone. And then you can also see osteonecrosis of the jaw. Those are kind of the big buzzwords that you'll find if you Google these drugs. But they're very, very, very rare. All right. And then I wanted to touch on the role of hormone replacement therapy, especially in bone health. So, NAMS, which is the Menopause Society, and has a position statement that's still been in place. Hormone replacement therapy remains the most effective treatment for vasomotor symptoms and the genitourinary syndrome of menopause, and has been shown to prevent bone loss and fracture. Hormone therapy can prevent bone loss and treat menopausal symptoms, but it does require individualized discussion with your providers to talk about risks versus benefits. And it is most effective in early menopause. So having these discussions early on is the best choice for you. Sometimes even while you're in that perimenopausal period, if you're a patient with multiple risk factors as well. Estrogen is FDA approved for the prevention of postmenopausal osteoporosis. Now, notice how this is prevention and not treatment. So, if you are diagnosed with osteoporosis, just going on hormone replacement therapy isn't going to necessarily fix that. You might still need to consider that pyramid, and consider all of the three factors to help treat your osteoporosis. So, in summary, bone loss accelerates during menopause. Lifestyle changes can make a significant impact Screening is essential, so making sure you're attending your annual exam with your GYN, even if your pap smear isn't indicated, still important. We talk about other things as well. And then going to your wellness visits, even primary care doctors are very in tune with these recommendations and guidelines, so they can also be screening you as well. And then, don't lose hope. It's never too late. There are effective treatments that are available, but they do require careful discussions with your providers. And then proactive care, like lifestyle modifications and fall prevention, does prevent fractures. Here are some resources. They'll be available for you guys when you have the recording. But this was that website, the bone health and osteoporosis.org, where some of those exercises were listed. Um, some of these books are also really good as well. Unbreakable, Exercise for Better Bones. Yeah, and then, looking on Instagram is okay. Following reputable sites do provide good information. And then find an OBGYN you love who will educate you, take the time to calculate your frac score and talk to you about prevention. Thank you for your time. Does anybody have any questions?
All righty. Thank you, Dr. Persnani. So we do have a few questions, and obviously everyone feel free to keep them coming. I'll just go from the top down. So the first question is, why do bone scans only look at the left side of the body?
That is a good question. I think it varies. I've seen some patients have the right side, but I think it really just they're thinking in theory like both sides are equivalent, but I actually don't know the answer to that. I'd have to phone one of my radiologist friends.
Okay, next question. Do you have any recommendations for exercises that strengthen the hips?
Yeah, actually that like website that I mentioned, so I think I came up, this was actually like a hip strengthening exercise. B, hip and back. So this is a hip abductor strengthening. And if you go to that Bone Health and Osteoporosis Foundation website, you'll find many more exercises like that. And then, you're not alone in this too. Like, there are physical therapists. You can always get a referral from your doctor, and they are here to help you with things like different exercises targeting different muscles.
Perfect. Is taking omeprazole, sorry if I mispronounced that, a
Mhm.
risk factor?
Not a risk factor, but it can affect your absorption of calcium. So it won't necessarily make you get osteoporosis, but remember you need the building blocks. So you want to be careful about the calcium supplement that you're using. So this is the calcium citrate is what you should be using if you're on omeprazole.
Okay. And if your bone scan showed osteopenia, can it get better through strength training and diet?
Yes, 100%. I've seen it. I see it all the time.
Perfect. And since we're on the calcium slide, is it better to take calcium carbonate to get in the calcium rather than just a calcium vitamin?
The calcium vitamin should still say what type of calcium it is. So I would just confirm on the label. It should say what form of calcium it is being like given in. Like if you're using a multivitamin, it should still say what kind of calcium is in there, but you want to calculate the amount, because if you're postmenopausal or greater than the age of 51, you should be getting at least 1,200 milligrams, which most multivitamins, like you just can't physically fit that much in the tablet. So you would have to take another supplement on the side.
Okay. And can you take calcium even if your blood calcium levels are at the higher end?
Um, I would guess so. I mean, I would make sure you don't have I would talk to like your primary care about that. There's certain conditions where you don't want to take too much calcium. But I'm not 100% sure about that. So I would I would have to talk to like a primary care doctor to see, but usually that is not reflective of dietary calcium. Yeah.
Okay. And do you think weighted vests for walking are good, slash, do you recommend them?
Yeah, I definitely recommend weighted vests, the ankle and wrist weights, especially it can kind of kill two birds with one stone. You can be doing your weight bearing exercise and kind of your training in one.
Perfect. And is there an absolute age where HRT is not started? For example, if you're greater than 60 years old?
Yeah, exactly. Yeah, it's greater than 60 or 10 years greater than 10 years from when you went into menopause. That's usually the rule of thumb most providers will follow. That's what's recommended.
Okay, and next question. This might be a question for the user's primary doctor, but it's I have osteoporosis and haven't scanned annually for years. No one has ever mentioned TBS. What can I do?
It should be like I said, not all bone centers report the TBS. But if you already have osteoporosis, it really wouldn't clinically change our guidance. You can definitely see if there's a different imaging center you can go to. But the TBS really comes into play if you're in that like gray zone where you have osteopenia, but then your TBS can kind of tip the scale and give you a higher FRAX score, which would then put you in a position where your doctor may recommend treatment. Um, but if that's something you're interested in, you might just have to find an imaging center that can report that.
Okay, and do GLP-1s affect bone health in one way or the other?
Um, I feel like the data is still out there for this. If you're thinking about purely just diet, just the diet, right? Like if you are on a GLP-1, in theory, you are consuming less calories, you're consuming maybe not having as well balanced meals. So if you're not taking supplements with a GLP-1, I would say that yes, it could have effect on many things, bone, skin, hair, and we do see that. So I would definitely talk to your provider that is prescribing the GLP-1, but that would be my theory.
Okay, and this one may have been just a communication, but is it 1,200 or 12,000, I'm assuming milligrams of calcium per day?
1200.
1,200. Okay,
1,200 milligrams per day.
all right. Any thoughts on Evenity?
Um,
Evenity.
yeah, I'm not 100% sure on Evenity. Um, yeah, I would have to do a little bit more research into that, I think, on how that would play in with osteoporosis.
Okay. This is more of a personal question, but I think kind of making it more applicable for the community. Um, will HRT help improve bone density if I'm in menopause?
Yes, it will. It is in theory supposed to help with that because it will be giving you estrogen, which if you remember back to this slide, Um, one of the things that estrogen does is it increases your bone mineral density. It inhibits osteoclasts, which are the cells that absorb the bone or break down the bone. Um, and then these are the other, it upregulates this hormone called rank ligand, which is a really important for osteoblasts, the building cells. Is kind of like the enzyme that activates them. So yes, estrogen, hormone replacement therapy, it is FDA approved for prevention. And yeah.
Okay, and if taking anastrozole, is there anything additional to focus on beside what's already been discussed?
Um, Not really. Anastrozole is, going to decrease your body's estrogen, which, for the reason patients are usually on is for hormone therapy for breast cancer. So we want to reduce their estrogen to prevent, any type of recurrence. So, it's really, doing the exercise, weight-bearing exercise, diet, nutrition, um, but we wouldn't like put a patient who has a history of breast cancer on hormone replacement therapy. So it's really lifestyle modifications for these patients. And then unfortunately, we have to kind of just deal with the consequences. And a lot of patients who are end up needing like a bisphosphonate as well when they're diagnosed with osteoporosis.
Okay. And this question, I think you kind of already answered, but if you could just reiterate, this person asked, can osteoporosis be reversed?
Yes, it definitely can, especially if you focus on the three building blocks, the three pillars of treatment, diet and exercise, lifestyle modifications. Yeah, it definitely can be. But most patients will stay on treatment even once they see the effects on their bone density, where that score will improve. But most patients will stay on treatment for 3 to 5 years and then discuss doing something called a drug holiday with their providers.
Okay. And the next question, you guys are totally testing my ability to pronounce medications. Does glucosamine chondroitin work in place of calcium?
No, you would still need calcium and vitamin D.
Okay. And is it better if there's, or better in quotation marks, if there's osteoporosis on your father's side versus your mother's side? Or is it if it's just in your family, no matter what side it comes from?
Correct. Yeah. Family history is both maternal and paternal is equivalent and both should be reported. Yeah.
Okay. And can bone density, actual scans, and scores improve after menopause?
Yes. Yep. With lifestyle modification, treatment, yeah, you can reverse your bone density.
Okay. And does hyperparathyroidism have an effect on bone density?
Um, I would guess yes. I feel like that's a question definitely for an endocrinologist. It definitely kind of, but thinking that we are often targeting those the parathyroid hormone for treatment of osteoporosis, I would anticipate that it does play a role, just like thyroid disease does too. But that would be a specific question to talk to your endocrinologist about.
And if you have osteopenia, can it be reversed or improved with treatment?
Yes. So if you have osteopenia, most doctors will recommend that you do lifestyle modifications, diet, and exercise, unless your FRAX score shows that you have a major osteoporotic fracture risk of greater than or equal to 20%, or or a hip fracture risk of greater than or equal to 3%, then you would be offered like medical management with one of the drugs, most likely a bisphosphonate.
Okay. Can you take calcium supplements if you have calcified kidney stones?
You definitely want to watch your calcium intake if you are prone to kidney stones. But again, this would be a personalized approach that you might want to talk to your urologist about. But definitely, dietary calcium is preferred in all stages, but supplements, I would definitely talk to your urologist about.
Okay. And this individual is asking if you can repeat the guidelines for when to begin HRT.
Yeah, so you want to start it within 10 years of menopause, and before the age of 60.
Okay. Interesting that you're an OBGYN, which specialist is best suited to treat osteoporosis?
That's a good question. So, I think there are many. OBGYNs are primary care doctors, rheumatologists, endocrinologists. It just depends what your provider kind of feels comfortable with. I would say most OBGYNs feel very comfortable interpreting bone density, initiating HRT for issues with your bone, like osteoporosis prevention, and then starting like a first line treatment like a bisphosphonate and monitoring you on that. But sometimes if you have other comorbidities, like other conditions, like the question about parathyroidism, that those patients would be better managed, or a patient who has, breast cancer and is on anastrozole would be better managed by their specialists.
Okay, and how many days a week should you be doing strength training to improve bone strength?
Well, every day would be great, but we know it's not realistic, so at least 3 to 4 days a week.
Right. And if someone was thin their entire life, how do we know if they always had low bone density?
Um, I wouldn't necessarily expect that unless there was some sort of hormonal issue, like if you have premature ovarian insufficiency, deficiencies with your thyroid or parathyroid hormones. I wouldn't necessarily anticipate just being thin when you're young to be a risk factor because you still have estrogen. Um, so that's something I think again, not doesn't necessarily mean that you have osteopenia when you're younger, and it's just considered a risk factor. So, yeah,
Okay. And is taking calcium in any way related to breast calcifications?
no.
Perfect. And then can a person with a very low score in the spine have to take medication or can it be reversed with exercise?
Um, this again would be an individualized discussion. You would be offered medication, but it really comes down to like what you prefer to do. But if you have osteoporosis, you would be offered medication.
Perfect. And then I think the last question we have in the chat right now is what happens after the drug holiday that you had mentioned?
So then we would watch patients off of the medication. We'd repeat a bone density 12 to 18 months. And if it's stable, then you can continue your lifestyle modifications and hopefully stay off of the medication once it's been reversed, once the bone density's been reversed.
Perfect. And another question just popped in, or a few more questions. What is osteopenia?
So osteopenia is defined as weak bones. So if we, look at just the DEXA scan, it's looking at your T score. So it's like that gray zone in the middle zone where it's not considered normal bone mineral density, but it's also not considered osteoporosis.
What is the difference between weight training and strength training? Can you give examples?
Um, I would say they're pretty, in my mind, the same. It's really like using an additional weight on top of your own body weight. So I would say strength training and weight training are in one. Strength training could also be without weights. So that would be like the exercises that we had seen in that website. Like this would be considered strength training, but you can easily add weights to your strength training as well.
Okay. And can taking calcium cause heart problems?
Not from my knowledge, dietary calcium is not considered like going to be causing any heart problems that I can think of.
Perfect. And what if there is a decline after that drug holiday you mentioned?
So then we would put you back on the medication, on the bisphosphonate that you came off of.
Okay. And would aqua aerobic classes use strength training or be classified as strength training?
So it wouldn't be classified as weight-bearing exercise, but I guess in theory, if you're using some sort of weight while you're like with your arms, but it wouldn't be considered weight-bearing exercise, any type of swimming or underwater, because of the effects of gravity.
Okay. And how do you get a T score
It would be listed in your
or Z
report.
score? Sorry.
Yeah, it would be listed in your report on your bone density scan.
Okay, perfect. So that is all of the questions that we have. So thank you so much, Dr. Persnani. This is a
Yeah, of
great
course.
presentation, great discussion.
Thank
At this
you.
time,